All right, let's jump right into this explainer. If you're a radiation oncology resident, you already know the deal. Malignant cases completely dominate your textbooks, but benign conditions, they're going to make up a highly practical and honestly sometimes incredibly challenging part of your actual day-to-day practice. So today, we're dissecting a massive retrospective study from Hanover Medical School. They looked at over 800 irradiated hips to help us build a really solid clinical decision guide for two major culprits of hip pain: coxarthrosis and greater trochanteric pain syndrome, or GTPS.
Here's our roadmap for today. We'll start with the benign hip dilemma, move into contouring the target volume, look at efficacy rates, predict outcomes for both coxarthrosis and GTPS, and then wrap up with some solid clinical takeaways. Let's get to it.
Part 1. The benign hip dilemma.
Picture this, because you will inevitably face it on the clinic floor. It's a standard afternoon, and you're reviewing the day's consults. Orthopedics just referred an older patient with refractory hip pain. Maybe it's coxarthrosis, maybe it's GTPS, and the pain just won't quit. Now you're in the hot seat. They've already tried NSAIDs, physical therapy, maybe even some corticosteroid injections, and absolutely nothing has worked. The orthopedic surgeon is basically asking, can radiation fix this? So how do you evaluate them? Are they actually a good candidate? And what exactly are you going to prescribe? Well, according to the S2E guidelines, when conservative therapies fail, a 3-gray course of low-dose external beam radiation therapy, or LD-EBRT, is a highly viable, entirely evidence-based tool in your arsenal. And the standard prescription here is incredibly well tolerated. We're talking 6 fractions of 0.5 gray each, usually given twice a week. It sounds like a tiny dose, right? But we know from in vitro and in vivo studies that these low doses have surprisingly potent inhibitory effects on various inflammatory effectors. Moving right along to part 2, contouring the target volume. Now, what's really fascinating here is how we actually define that target volume, which, let's face it, is your bread and butter as a resident. Contouring benign disease is a whole different ballgame compared to a malignancy, but precision is just as absolutely crucial. Looking at the planning target volumes, or PTVs, you can really see the difference between covering the entire hip joint versus just targeting the inserting areas of the gluteal muscles. For coxarthrosis, you're looking at a clinical target volume encompassing the entire hip joint and the medial part of the femoral neck. But for GTPS, the target is much more superficial, tightly focused right on the inserting areas of the gluteal muscles at the greater trochanter. And then, of course, you have the combined approach. Here's the really crucial takeaway, and honestly, it's a massive win for radiation protection. The data clearly shows that smaller, tightly contoured fields perform just as well as larger ones. No way around it. For GTPS, the researchers found that irradiating just the peripheral structures, those trochanteric insertions, yielded the exact same positive outcomes as irradiating the whole femoral head. Plus, if you happen to spot incidental grade 1 coxarthrosis on your planning CT for a GTPS patient, ignore it. Seriously, do not expand your PTV. Keeping those fields small minimizes scattered radiation to intrapelvic structures, and most importantly, it spares the bone marrow. That reduces any theoretical long-term leukemia risks, which is huge, especially for your younger benign patients. All right, part 3, LD-EBRT efficacy rates. Let's talk numbers, because when you sit down with your patient, you need to know what to confidently quote them. For GTPS, you can expect a really impressive 64% overall response rate. Think about that for a second. That means nearly 2/3 of patients who have already failed multiple other conservative therapies are going to experience either a partial or complete response to this super brief, non-invasive treatment. Now, what about coxarthrosis? The overall response rate there sits solidly at 58% across the patient collective. Again, for a refractory cohort, patients who are out of options, getting nearly 60% of them to respond to a total of just 3 gray is a fantastic clinical outcome. But to really master this in practice, we need to dig into why some patients respond and others just don't. So why the difference? It all comes down to contrasting their underlying pathologies. GTPS is highly actively inflammatory, whereas coxarthrosis is primarily a degenerative condition, but one that has specific inflammatory windows. You've got to remember, low-dose radiation works primarily by hitting the brakes on inflammation. It does not reverse structural bone damage. GTPS is basically an aseptic inflammation of the bursae and gluteal tendons. Coxarthrosis, on the other hand, is osteoarthritis. It's actively destroying cartilage, but it flares up with acute inflammation. So long story short, radiation is most effective when inflammation is the main thing driving the patient's pain. Part 4, predicting coxarthrosis outcomes. Okay, so who is the ideal candidate for coxarthrosis treatment? Or better yet, who isn't? Let's look at the negative predictive factors. Older age and higher BMI are significant red flags here. This is likely because older, heavier joints are stuck in a chronic degenerative phase that radiation simply cannot fix. In the multivariate analysis, patients over 70 had an odds ratio of 2.4 for treatment failure. Patients with a BMI over 25 had an odds ratio of about 2.0. The study actually found that non-responders had a median Kellgren-Lawrence score of 3, which means marked joint space narrowing and large osteophytes. At that stage, mechanical degeneration has completely taken over. Radiation isn't going to magically grow back cartilage or shave down bone spurs, right? But here's a really interesting twist. Unlike so many other conditions you treat, the duration of symptoms before they see you has zero correlation with your overall response rate for coxarthrosis. None. Whether the patient has been in pain for 4 months or 4 years, as long as they haven't completely aged out into severe end-stage degeneration, they basically have an equal shot at responding if you catch them during an inflammatory flare-up.
Moving to Part 5, predicting GTPS outcomes.
Now for GTPS, the rules change entirely. Here, time is absolutely of the essence. Waiting over 12 months or trying to treat around a foreign body, like a hip prosthesis, significantly tanks your chances of success. Why is that? Well, early tendinopathy is all about acute inflammation with neovascularization. But as it gets chronic, once you cross that 12-month mark, the vessels regress, scar tissue forms, and pain receptors lock in. It literally morphs from an inflammatory problem into a structural scar problem, which we know radiation handles poorly. On top of that, if the patient has a hip prosthesis, that hardware is continuously irritating the tendon. It causes chronic re-injury that 3-grade radiations simply cannot pace.
But wait, there is one universal red flag you've got to watch out for across both of these conditions. If your patient comes in and reports a pain spike halfway through treatment, statistically speaking, they're likely headed for a non-response. The study closely tracked an initial increase in pain right at fraction 3. In both GTPS and coxarthrosis, this early pain spike strongly correlated with ultimately failing the whole treatment course. This is just a vital, practical piece of clinical knowledge to keep in your back pocket when you're doing those mid-treatment check-ins.
Oh, and let's quickly bust a common clinic myth. The data completely ruled out the weather. Whether you treat your patient in the dead of winter or the middle of summer, the efficacy remains exactly the same. You know how patients often swear their joints ache more in the cold or the damp, and there are all these theories about barometric pressure? Well, when it comes to the actual biological efficacy of low-dose radiation, the season you flip the machine on has absolutely zero impact on the final outcome.
Finally, Part 6. Clinical practice takeaways.
Let's boil all this down to what you're actually going to do in the clinic tomorrow. These are the guidelines that will help you confidently evaluate those orthopedic referrals, build safer plans, and manage your patient's expectations. First, when you see a GTPS consult, check their timeline immediately. If they're under 6 months, fast-track them. Second, when you sit down at the planning software, keep your PDVs tight to the specific pathology. Do not overtreat based on incidental findings. Third, when you're consenting patients, confidently quote that 60% benchmark success rate. And lastly, if you get a coxarthrosis consult for a high BMI patient over 70, you need to have a really honest conversation with them and with orthopedics about the likelihood of mechanical degeneration just overriding any inflammatory benefit.
I want to leave you with something to chew on. Considering the truly excellent safety profile we have here and those strong response rates, maybe it's time we reconsidered our threshold for initiating benign radiotherapy. I mean, if GTPS responds so much better in the acute inflammatory phase before all that chronic scarring sets in, are we actually doing our patients a disservice by forcing them to fail months and months of other therapies first? As you step into your role as a radiation oncologist, you now have the data to back you up. You can advocate for earlier intervention, tighter fields, and ultimately better pain relief for your patients. Keep these parameters in mind, and you are going to navigate your benign clinic with absolute confidence.